ultimately it comes down to satisfaction, patient satisfaction. If
Yeah.
satisfied, then we as a clinic, as a dentist, we'll go the extra mile to make them as happy as possible.
Okay. I remember, doctor, when back in India, when I was working with one orthodontist. So he was using Beg's appliance. So he always used to over-treat, especially biomaxillary proclination. We used to get the cases, so 4/4 extraction cases. So he always used to get more overcorrection a bit, because he used to say, कि once they will remove it, there will be a little movement in the teeth, and they will put a retainer, and then it will stabilize. So this is something same in the Invisalign also?
Well, no.
No, right?
No. Okay, so overcorrection in certain areas are fine. But see, the thing is, it's a very tricky thing to do, an overcorrection. Okay, very, very tricky. If you don't do it rightly, then post-treatment, it can backfire. Okay. So, say for example, we push the teeth inside, inwards, and I overcorrected it. And if I'm predicting that it'll come out, when it come out, the gaps will appear in between the teeth.
Okay.
And that will be even more complicated, because now the patients are complaining about the gaps. Now, and to put the braces back, most of the patients, when they're waiting for the day to remove the braces, right?
Braces.
Okay, then they're waiting for that day to finish off the braces.
Yeah.
So when they wait, when they get all the braces out, and then when they see the gaps appear, then now the doctor is saying, I need to put the braces back again. It can be a lot more unsatisfactory, and patients will we might lose the trust of the patients also. So this is one key area of it. We do have done some overcorrection for some of the patients, but this is on the bite-wise. On certain, like say a tooth, we tried to rotate the tooth, but it didn't come all the way in, irrespective of trying multiple times. Then I might go for overcorrection, so that like it moves a little bit more additional. But ideally, when we finish, it finishes on that side. This is where the Invisalign. So Invisalign is a piece of plastic. So after some time, it will lose its power to push. So on long-term wear, it becomes a little like, so when you wear the Invisalign for the first time, the power of it is intense. The teeth moves, and after a long-time wear, the Invisalign, not a lot, but small kind of flexibility appears on the Invisalign. So it's not giving the additional pressure that is required to complete the final movement. Sometimes we are talking here about like small, tiny movements. The big movements, obviously, a lot of things happen. But when we talk about this millimeter-wise movements, like small, tiny movements, is where I might use a little bit of overcorrection, so that like it will end in the perfect position. So only in those cases I use. But when it comes to space closure, overcorrection and all, no, it can actually create a little bit more, it might backfire. Now, another problem is like our teeth generally are in almost in its ideal position compared to where the lips are, where the bone is, where everything is. There can be some differences, like say a patient who's in the childhood was always sucking their thumb, and that has caused the teeth to move in completely different direction. This is a completely different story. A patient whose milk tooth didn't fall on time, and the permanent tooth came out, and then it resulted in a lot of crowding. This is other than that, most of the time the teeth are in its most ideal position. Now from this ideal position, we are moving the tooth to the desired position, or according to the patient, according to the face, according to like a lot of other things, right? So what happens is, there's always a tendency for the teeth to, because our tongue pressure causes lots of stress or pressure on the teeth. And it's always pushing the teeth to outwards till it goes back into its resting position. Now I feel good as a tongue. Okay, I got my space back. So, and the power can be intense, even after wearing the retainers, even after the tongue is constantly pressing. So if you do a little bit of, even then, then the teeth position moves, gaps open up, then we have a problem. Then we need to put back the aligners back in to push the teeth back and so on and so forth. So this kind of things happen.
And doctor, I wanted to know, there are some cases, they are really, upper teeth really out, like a quite proclination we can say. So do you feel like some cases extraction is needed along with Invisalign, or how it's?
Okay, now most of the cases that I have resolved is a non-extraction. We don't do any extractions.
Yes.
If it is a case that needs extraction, I will definitely refer it to a orthodontist. Braces.
Okay.
Because the control is it's more controlled. Some doctors, some orthodontists also do a combination. They do Invisalign with the braces. I don't do that, but
okay.
I only do whatever is possible within the Invisalign itself. Okay. Now, some of the specialized treatments like this, I refer them to an orthodontist, let them handle it properly.
Okay.
Now, most of the cases that I was able to resolve is through a process called IPR. IPR is the full form is interproximal reduction. So we create small spaces in between the teeth, allowing more room for the teeth to go inside. And with this, we have been fairly successful in majority of the cases. Because when we tell our patients that they need to sacrifice 2 healthy teeth or 4 healthy teeth, they are happy to have their teeth sliced than having a natural healthy tooth removed out. So they are happy with it. And but irrespective of that, I'll tell this, even if there is a limitation as to how much of reduction we can do. We cannot simply go and make the teeth literally half in order to have the teeth moved completely. So in this case, we tell them this is the best position that we can get. We cannot slice anymore to go in further, because that will cause sensitivity to the teeth. It can cause like a lot of other problems to the teeth as well.
Okay. And sir, what if some patients, they say they are not want IPR? So those cases can be managed without IPR as well?
So, but we show them the limitations.
Limitations.
We show them the limitations, the best that we can get.
Okay.
And that's it. We cannot do more than this.
Okay.
So, and without IPR, we cannot go further.
Okay.
And the patients really understands that. And the patients who says like, I don't want IPR, they also tell me, I don't want it to be as perfect. I just want to improve it, and I'll be happy with it. I don't want any IPR. I don't want you to touch my teeth.
Okay.
And I'm actually happy like this. A small improvement will also make me happy.
Okay.
And I'm okay with that. So then we respect that and we do that. Here we give that.
Okay.
The good thing about the Invisalign is everything is pre-detailed or pre-designed. So everything is on the software. On the software, even the reduction, how much of reduction that we have to do is all being planned, pre-planned, before even we do it on the patients.
Okay.
So the patients are also aware how much of reductions we are going to do and all that, and in which key areas are we going to do. Everything is shown on the software. Okay. So there is no guesswork. So all we have to do, and I always underperform IPR.
Okay.
But I don't go all the way there, and I will only continue with the IPR if it is required. So if it is like 0.3 or 0.5 mm is required between the two teeth, I might end up with 0.3, maybe 0.4, but not all the way till 0.5. And I'll wait and watch to see how it is going. So if sometimes it's going very well, then I'll every time that the patient comes in, I'll keep assessing, and should we require, then I go a little bit extra. I don't want to overdo it.
Okay. And sir, do we get some kind of like patients like they have implants in their mouth? So they ask me like, can we do Invisalign treatment with implants in their mouth? So, yeah.
Yeah, definitely we can do implants. We can do aligners with the implants in the mouth. The only thing is that the implant will not move. The rest of the teeth will move except for the implant. So when we design, when we design the way that the teeth are going to shape, we keep this implant teeth in mind, and we center all the rest of the teeth according to that implant teeth. Now we show this to the patient, but if the patient is not satisfied, needs more improvement, then we can design it in a way ignoring the implant. We'll design the rest, and then we'll tell the patient at the end, once we are done with the Invisalign, maybe we will have to remove the implant crown and put a new crown that will match with the arch. That'll go with the arch, how well it goes with the arch. And this is possible with the back ones. Majority of my cases, we are able to do it without having to replace the implant crown or anything. But very few cases that we advise our patients is best to change the crown so that it will fit in very well with the rest of the teeth. But it's a big challenge if a patient has a implant in the front tooth. So now we align the rest of the teeth according to that implant, or we have to, now if the patient has a new aesthetic concern, no, he wants it to be better because this was done in an emergency. Most of the time, the patient might have lost the front tooth in an emergency, like in a fall accident or some kind of trauma. And they had to go through this treatment of implant placement as an emergency treatment.
Yeah.
So at that time, the doctor would have placed the implant based on the rest of the teeth position.
Yes.
Yeah.
Good.
So now, once the patient, after a few years later, now the patient wants to improve the smile. Now, but this implant tooth is in its way. Now, how do we do this? So what we do is we see if the modifying the rest of the teeth along with the around the implant, is it good enough? Then we just modify the rest and then change the crown to a new crown that will look nicer on the patient. But if the patient wants more perfection, the teeth needs like more perfection, then if changing the crown of the implant is not enough, then we may have to remove the whole implant and put a new one in according to the new position of the rest of the teeth, which is actually quite challenging. It's very challenging. It's not impossible, but it's quite challenging for both the doctors and the patient because it's an aesthetic area. And removing the implant from an aesthetic area, which will also involve a lot of bone loss in that area, which means we need to build up bone and then place a new implant. So it's going to be a very tricky position. As far as like if the patient really understands what they have to go through, we are ready to perform. So, but we educate our patients. These are the things that they will have to go through. Now, patients come with, everyone comes with a different smiles. Yeah. Some have a more gummy smile. Yeah. Some lips are thin. They have thin lips type. Some people have a thicker lips types. Yeah. So all of this defines the final position of the tooth, the resting position of the tooth. So if sometimes we may be able to get away with certain things if their gums are not visible enough, or in some cases if the lips if they have very thick lips, again we might be able to get away with a few things. But for patients who have very thin lips and they have a heavy gum visibility, the aesthetic challenges are huge. It's very huge. Yes. The good thing about this time and age is because of the technology that's around us. We can use the technology to plan things, how they look, and show to the patient, is this something that you would be happy to achieve or not? So the patient can also have an idea about the best thing that they can get according to their smile conditions or their skeletal means how their bone or overall facial appearances. And by far, this is the best position that we can, or this is the best that we can do. Anything more than this will require extensive surgery, which means we'll have to refer them to a hospital or somewhere that they can do a major work for them. So this is how we educate the patient. So one way is that the patient knows what's going to happen to them, where they're going to happen. Is this something that they're okay with? We can show it to them by taking photographs. We can do some, we can place this new design on the smile and show it to them how they look like. We also do mock-up. So the patients can, we have physical mock-ups, we have digital mock-ups, we have mock-ups direct mock-ups. We can use the same mock-up to directly transfer it into the patient without changing anything. So the patients can themselves have a look at themselves and see like how they look like at the end, and if this is something that they want to achieve. Because sometimes patients come with unrealistic expectations. So they have, they want to look like a movie star, or they want to do this, this kind of thing. So this is where the challenges of the doctors are, how we can set the expectations right for the patients. So with this all tools, we are able to help them out even better.